I'd like to welcome up to the podium two friends of mine, Seth Finkelstein. I met Seth in 1999. I was injecting rodent hippocampi with, I can't even remember what. Oh, no, I think I was recording from their hippocampus electrophysiology. And Seth, his lab was right next to mine. He was running at Mass General a very top flight stroke ischemia model in mice. And we became fast friends. And he is still on staff at Mass General as an associate neurologist. And he has also founded his own company called Biotrophics, which is a pharmaceutical research company. And I understand that's doing quite well. So I'm glad he came down from Boston today to moderate with us. Ella Warkowski is a neurointensivist at Winthrop. She's the medical director of the Neuro ICU, and she's also a professor of clinical neurology at Stony Brook. So welcome and thanks for moderating. I'm going to just show a couple of cases, a couple of carotid cases as advertised. Unlike most of the things in neurosurgery, if you want to be involved with carotid stenosis, you really do have to know about the trials. The referring doctors, the neurologists, the internists will know about the trials. And this is actually something that Mark Mayberg kind of hammered into my head when I was out in Seattle. Mark, of course, was the principal investigator on the Veterans Affairs trial in 1991, and he's an expert on trials. I'm not going to go through all of them, but as I said, quite frankly, if you're not aware of the trials, then it's hard to really discuss what to do with carotid stenosis. The trials were performed and published, however, many years ago. The asymptomatic trials that I'm showing you here were published in 1991. So everything needs to be interpreted with that 20-year kaleidoscope. The asymptomatic trial, as we know, there was no Plavix or Agrinox really back then, no CT perfusions or spectroscopy being performed. And what they found was, in the hands of very talented surgeons with morbidity of less than 3%, you will help patients who have carotid stenosis more than 60%, even if it's asymptomatic. And as a resident at Mass General, I clearly remember that on a slow day, simply doing Dopplers on a medical floor would generate a case, because all you had to hit was 60% asymptomatic, which is rampant. We know that for asymptomatic disease, men were benefited more than women. And again, the morbidity of the surgeon had to be quite low in order to be affording any benefit. But again, that was an older trial. It's now 2013. How about for symptomatic carotid stenosis? The NASIT trial, most everyone in the room has heard about it. Essentially, what it showed is if you've had a symptomatic event, TIA or stroke, in the distribution of that carotid, if the stenosis was more than 70%, it was a home run. That was the results of NASIT. Okay, meaning if you've got more than 70% stenosis, and it's a symptomatic lesion, and you operate on that lesion, you take the 2-year stroke event rate from 26% with medical therapy down to 9%. The NNT for treating carotid stenosis was 8, meaning in order to avert 1 stroke in symptomatic carotid stenosis, you had to operate on 8 patients. And I'm not going to go through the rest of the trial, but I will point out that for folks with moderate stenosis, so folks who only had 50 to 69% stenosis, you really weren't hitting a home run anymore. And again, in order to even get that benefit, the surgical stroke risk had to be less than 6%. Again, here are some tidbits that you don't often hear about on rounds. And again, I myself would have ignored, but Dr. Mayberg kind of just kept pushing me towards the original publications and said, read the trials, to actually know what was said in those trials. If you had moderate stenosis, there was no benefit doing endarterectomies on women, on people with diabetes, or on folks who had prior TIAs. So there's a lot of small details in these trials that if you don't read the primary sources and you don't pay attention, you're not going to be getting the surgical benefit that you might think you're offering the patient. Again, not much Plavix, Agrinox, or advanced imaging being done back then. Let's ramp up to 2010, the CREST trial. You absolutely have to know the results of this trial. It's a phase 3 study, included both symptomatic and asymptomatic stenosis. It was a randomized trial, 2,500 people, looking at the $64,000 question, or I guess for carotid stenting, since the government doesn't pay, it's a $0 question, but whether or not we're going to be doing endarterectomies or carotid stenting on people for symptomatic and asymptomatic disease. Remember, unlike the Sapphire trial, these are standard risk people. So these are not surgically high risk people. These are standard risk people. Primary endpoints, the usual ones: stroke, heart attack, death. The results of trial was essentially that there was no significant difference in outcome between stenting and endarterectomy in total. However, the folks that got stented had slightly higher risk of stroke and during the procedure, and the folks that underwent endarterectomy had slightly higher risks of myocardial infarction. The surgical risk for both endarterectomy and stenting was actually quite good. So surgeons have figured out how to do endarterectomies. Interventionalists have figured out how to do stenting with reasonable morbidity. The guidelines, as you can see, have been rehashed to try to incorporate the results of the ongoing trials over the last 20 years. There's not much new here in the guidelines published by the Heart Association. Essentially, if it's more than 70% it's symptomatic, it's a home run. If it's less than 70% symptomatic, be careful. Endarterectomy or stenting, both should be considered. For asymptomatic disease, again, they quote 60% based on the ACAS trial, but I think most of the good vascular surgeons and through a lot of psychotherapy, I'm now friendly with a lot of vascular surgeons. I could just pause after the jokes. I don't have a problem with that. It's my symposium. If you need me to pause or throw up a green light or something, or most folks are really not operating on asymptomatic disease until it hits at least 70. I personally like to see 75 to 80%, and I don't operate on older folks or sick people for asymptomatic disease. But here's an interesting case. This is a case that I was asked to get involved with. 81-year-old lady, hypertensive, diabetic, coronary artery disease. Maybe I should just list which organs were working, huh? Renal insufficiency, 35 over 1.4 was her BUN and creatinine. Taking her baby aspirin. Gives a history. She had a big stroke 10 years ago, doc. Big stroke 10 years ago. Had some right hemiparesis, but she got all better. Okay. She comes in with a clear TIA. Had some dysarthria. The right arm was weak. Gets a Doppler. Carotid duplex shows more than 70% stenosis on the left side, the side of her prior stroke. Her MRI, no acute stroke, but as I'll show you, she had clear footprints of having a large prior hemispheric stroke. MRA was done without contrast, shows moderately to severe left internal carotid artery stenosis. I think the radiologists just read it that way to piss me off and make my life difficult. I don't know what moderately to severe is, but I guess you get the idea. Here's what her MRI of the brain showed. It's, she looks every bit 81 years old and every one of her comorbidities. Large area of encephalomalacia there on the left. She actually had a small old infarct in the right cerebellum. Just to give you a flavor of this lady. This is what her MRA showed. Kind of, irregularity there being read as moderately to severe. She's had a clear, what sounds like left hemispheric TIA. Supposedly her blood sugars there was a question whether they had dipped or not. It was unclear. She's neurologically better, and they've consulted me. The neurologist was strongly interested in a carotid endarterectomy for this lady. Seth, Ella, what do you think? Well, I mean, you know the case. So, Seth, what do you think about this one?
So, in the old days, 10 years ago, we look at the MRA, we look at the Dopplers, and make a case for surgery or stenting. We didn't stent in those days. Nowadays, we probably get a CTA.
Talking to the mic. She has renal insufficiency, 35/1/4.
Okay, you probably wouldn't get a CTA. That's a remark.
But did you know the case?
I don't remember.
Vaguely, okay.
But I guess I would start with asking how.
Talking to the mic.
Oh, I'm sorry. I guess the first question is, what is her prognosis? How sick she really is? What is her 5 years of survival? Is the surgery of any type intervention will be beneficial? Would put her for higher risk with all these risk factors? And also, how does this stenosis truly functionally affect her brain flow through the brain? I think these would be the two questions I would like to know before we even talk about intervention.
Those are valid questions. Her internist says she could definitely have 5 years. You know, that he's deferring to the neurologist who is asking for an endarterectomy. Proceed with endarterectomy. So this is what her intracranial MRA showed. I look at all the circle of villi on any patient that I'm going to do an endarterectomy on. The reason why is because although I do shunt and I'm comfortable shunting, I don't like to shunt. And I do not routinely shunt. And if I see someone that I really think is going to need a shunt, that in and of itself may be enough of a reason to take them for carotid stenting, in my opinion. This lady had no circle of Willis. She has no ACOM at all and no PCOM. I thought she was going to be a high risk for needing a shunt during an endarterectomy, but there was a lot of kind of pressure, I guess is the best word, from the neurologist and the internist and the family. People wanted an endarterectomy, so I went ahead and I broke down and scheduled the endarterectomy. Zogo Gowala, so I know you do a lot of carotids. What do you think about this case? Would you offer this lady an operation?
I think I would, John. You know, she has risk factors. All of these things are always a discussion with the family. I'm sorry.
The answer is I think I would. I think that you have a discussion, a frank discussion with the family, but she's had a history of a stroke. She's had a TIA, that's a bona fide TIA. She has a surgically treatable lesion, and I think she should be at least offered revascularization.
So I booked her for an endarterectomy, and then the morning of, one of the PAs called and said, by the way, are you bothered that the PTT is 51? I said, I've been bothered since I got involved in this case. So there was my out, right? So we got hematology involved. We worked the lady up. She had a positive lupus anticoagulant. Clearly had some hypercoagulable situation going on. To me, that was enough of a reason to kind of back off here. I did offer them possibly getting a CTA, possibly getting spectroscopy. The lady had only been on a baby aspirin. She had diabetes. I personally was not at all convinced that this lesion was more than 70%. I mean, this is a non-contrast enhanced image, and it's a very small vessel distally. So I decided not to operate on this lady. Now, this is a picture of two of my favorite men, Benjamin, my son, and my father, Ron Brisman. Ron is a 73-year-old, still actively practicing neurosurgeon at Columbia Presbyterian, where he's been for the last 38 years. He did carotid surgery there from 1972 to 1976. And when I'm in doubt and I really need to know what to do, I speak to him. One of his favorite sayings is, he says, a good surgeon knows how to operate. A really good surgeon knows when to operate. And a really, really good surgeon knows when not to operate. And in this particular case, That message was coming loud and clear. So I decided not to operate, and we're following the lady as an outpatient. We added Plavix to her regimen. I would consider a CTA to really define, is this more than 70%? But this was a little bit of a curveball, because I know at conferences like this, I'm supposed to show, all the great surgeries I do, and it's, borderline inappropriate for me to show a case that I decided not to operate on. But had I been one of those surgeons that I don't like very much, who gets up and grandstands about all the great surgeries that they do, I would have showed a slide like this on like how I do carotid endarterectomies. I put them on aspirin. I get a cardiology consult for every carotid. I usually have at least duplex, if not an MRA and a CTA. I do them under general anesthesia. I monitor them with transcranial oximetry as well as scalp EEG. I almost never shunt unless I absolutely have to, and I do not patch. Almost never patch. I usually don't image in-house, and they, generally speaking, should go home on post-op day number 1 or 2. Again, if I were one of those surgeons who would show cases that I was operating on, I might show a slide like this. This is an image of the transcranial oximetry, which monitors the oxygenation of the brain during carotid surgery. Here's the basic operation. The common, the external, and the internal are clamped. The plaque is dug out, and then the arteriotomy is closed. Again, if I were a surgeon who is showing cases that I operated on, I might show a cutesy slide like this. This is a picture that my dad took when he was on the Letterman Army base in 1974. I guess you could figure out which one is me and which one's my brother Mike. So here we are, scroll ahead 27 years or something like that. We're over at Franklin General Hospital, which is in Valley Stream. I think carotid endarterectomy can be done safely at a community hospital. I do like to operate, usually with another attending surgeon. I think that it makes the case go a little bit safer. Again, here are the transcranial oximetry probes that I use to monitor brain oxygenation during the case. Again, if I were showing you slides of an operation, I might show you myself cutting through the platysma or even meticulously removing plaque from the carotid artery here. Here's what the plaque looks like at the end of the case. And again, this is the kind of the picture you want to see, the bandage on the right side and the left arm moving. Here's another case. This is an emergency clot retrieval. This is a 64-year-old lady who came in and had a complete intracranial MCA occlusion about a week before this picture was done. She had a moderate non-disabling stroke. And then a week later, we imaged her, and her MCA system had opened up. And she had this in her neck. That's her stroke. She had a moderate left hemiparesis, but was anti-gravity. And this was her lesion, and she had flow now into the MCA. Mark, you operate on those?
How old is she?
64. She came in with an MCA occlusion, and then a week later it basically recanalized. She's got a non-disabling stroke, and she's got, very, very tight carotid.
Yes.
And the answer is so. I also felt like she should be opened up. I mean, this is a very tight lesion, so I booked her for an endarterectomy, and the night before I do an endarterectomy, I kind of walk down either to the angio suite or if there's been a CTA, and I kind of go over myself just to make sure that I'm going to be able to reach the thing. And I kind of count up, the cervical spine bones. And this is what I found on this lady. There's C2, there's C1. It was really quite high. The bifurcation was quite high, and I thought I was going to have to get up at least to here in order to do this operation. So I went ahead and just canceled the OR, loaded her with Plavix and aspirin, and came back and put a stent in this lady. she had a good outcome. Any other thoughts on that, Seth or Ella? Anything different? Sounds perfect from your vantage, Seth.
Yeah.
All right.
One question.
Yeah.
How soon after the stroke you go for ahead with the surgery, if you had to do the surgery?
That's a good question. And the question is, how soon after a stroke do you proceed with surgery? The guidelines that came out in 2010 say that you should do it that admission, that you should no longer wait, provided it's truly a non-disabling stroke, that within 2 weeks, which is essentially that admission, you should revascularize the carotid. So I think that's now become the standard. I had a few years ago been kind of dragging my feet a bit, letting cardiology chew on the patient for a few days, et cetera, but I wasn't really sure why I was doing that. So when I'm really not sure about something like that, I usually pick up the phone and call Mark Mayberg, and I asked him, I said, is there any reason to kind of wait a week or so? He said, no, you're just kind of waiting for a stroke to happen. So pretty much, if it's truly a non-disabling stroke, I call cardiology, and as soon as cardiology says that they're good to go and I can get an OR, I do it.